تمام. تمام. السلام عليكم. أنا طبعا بشكر أساتذتي على الدعوة الكريمة دي. دكتور محمد صلاح، مدرس جراحة مسالك. المحاضرة تبقى عن Prostatic Specific Membrane Antigen When and Why Clinical Point of View. طبعا في وسط أساتذتنا العظام بتوع الراديولوجيست أنا حاسس نفس إحساس الغزالة وسط الأسود. والمحاضرة ديت هي It is a clinical point of view from urologist اللي mainly depend on examination, and district examination is one of the important arm in diagnosis of prostate cancer. Prostate cancer diagnosis is dilemma which need a real partnership between urologist and radiologist. We should share our clinical data with the radiologist and also to inform him the data we need to reach to make him enable to give us more information. This is our agenda: introduction, molecular imaging, PSMA, what is it, indication and why, and our home message. At first, prostate cancer has a long natural history from being localized disease which needs surgery or radiotherapy plus minus hormonal treatment, then the development of recurrent or metastatic state which need hormonal treatment, then the development of castrate-resistant disease which need advanced systemic therapy. This long natural history making us in a need for more accurate diagnostic and radiological tool to follow up our patient. Prostate imaging is needed for primary clinical staging and also for follow-up of our patient. Biochemical failure is one of the greatest dilemma for follow-up of our patient which is treated, which means that rising PSA post-treatment and no myths can be detected on conventional imaging, as conventional imaging have very low sensitivity, especially when PSA is lower than 10 nanogram per milliliter. And to know that after radical prostatectomy, it is normal to not detect PSA, and biochemical failure is defined when PSA is more than 0.2 nanogram per milliliter. Prostate imaging have great advancement from the past to the present, and I will begin this lecture by this case scenario. Known patient with prostate cancer and treated with radical prostatectomy, and it was pathologically T2C N0. After 2 years, he developed biochemical failure as PSA was 0.5 nanogram per milliliter. Which type of molecular imaging will prefer? Fluorodeoxyglucose PET-CT or choline or fluocyclovine or PSMA PET-CT? We will explore our answer. We have two types of molecular imaging. But not the best. We have two types of choline, 11C choline and 18F choline. The most widely used is 18F choline because it have long half-life, but it is excreted through the kidney. Choline is involved in prostate cancer cell wall synthesis, but cancer detection rate is very low when PSA is lower than 1 nanogram per milliliter, and according to PSA doubling time more than 6 months is only 20% cancer detection rate. So choline PET is only indicated when PSA is more than 1 nanogram per milliliter and PSA doubling time less than 6 months. Fluocyclovine is better than choline. It plays an important role in sodium-based cell wall transport, and also it is FDA approved, and it is not secreted by the kidney. This is advantage for him against choline, and it is better than choline, and not recommended if PSA is lower than 1 nanogram per milliliter. So prostatic specific membrane antigen have high sensitivity even with large extracellular domain, which significantly increased expression in prostate cancer cell, and also its function is not clear. PSMA overexpression in non-prostatic solid tumor like ovarian tumor and GIT, breast tumor, and thyroid tumor. PSMA lesion has the advantage that it is highly specific for receptor, easy to be produced, easy to be labeled, and no host immune response. In the last decade, in the 20th century, Prostatic was the first FDA approved for targeting Bsma using single photon emission computed tomography, but was low sensitive because it was directed against the intracellular domain, which needs the cell, prostate cancer cell, to be divided and cell wall lysis to reach its target. So it was low sensitive. There are many different types of Bsma, like 68 gallium Bsma and 68 gallium Bsma and 18F Bsma. To produce Bsma bit, we have showed gallium generator and the lyophilized Bsma legend called kit. The patient not need to be fast, and the medication can be continued, and good hydration is essential. And dose 1.8 to 2.2 megabecquerel per kg body weight. It gives flushing with the same volume with saline, and we inject Oflasix after 60 minutes. Then we take a field of view from the base of the skull to the mid of the thigh, and then asking the patient to go to the toilet to have an image post that. This is a white and gray scale. There is intense uptake by the parotid gland and also the lacrimal gland, and it is by the kidney. This is the white as a colored scale, with the white the maximum uptake and the black is the lowest uptake. This is as an image for Bsma showing lymph node mets in prostate cancer. So when we should ask urologists to ask for Bsma, it is highly recommended for biochemical recurrence. This is the best option, but in the guideline, it is a grade C recommendation for primary staging and high-risk disease for nodal and distant metastasis. Why we should use Bsma? Simply, it is highly sensitive. Sensitivity of Bsma in biochemical recurrence in a systematic review study done on 1,309 patients, it was 42% when BSA was low as 0.2 nanogram, and it reached 95% for BSA more than 2 nanogram per milliliter. BSA doubling time was 92% for BSA doubling time less than 6 months. For nodal staging, the gold standard for nodal staging is lymphadenectomy and histopathological examination, but conventional imaging is mainly depend on size, and there is a difference to decrease the definitive size, some 8 millimeter in short transverse diameter or 1 centimeter in short transverse diameter, but Bsma can detect up to 50% of lymph node of 3.7 millimeter. We should know also that diffusion weighted FT was up to 100% versus bone scintigraphy was 89.3%. Also, in biochemical failure, Bsma have upper hand for bone scan, as bone scan only detect less than 10% of mets when BSA is lower than 10 nanogram, and the BSA doubling time is more than 6 months. Choline versus Bsma. Bsma has higher tumor uptake and higher tumor to background uptake, and also higher detection rate. The overall sensitivity of choline versus Bsma was 66% versus 88.5%. And also sensitivity at BSA is lower than 2 nanogram per milliliter. The choline was only 31% and Bsma was 72%. Bsma versus fluciclovine. Germany et al. 2019 done a comparative study on 15 patients for post-surgery biochemical recurrence. The detection rate for Bsma was higher than fluciclovine in all sites for prostate cancer. As we know, multiparametric MRI is a gold standard for local staging of prostate cancer patients, but Bsma shows some higher detection rate for lymph node than multiparametric MRI. Bsma PET MRI. In a study done to head-to-head comparison of between the CT and the MRI device, there was no difference between two devices. But when Bsma done with multiparametric MRI, it increased the more accuracy of TNM staging, and it can change the management plan and therapeutic almost in 1/3 of patients. Therapeutic use of Bsma. We can use directed radiotherapy by using 170 low Bsma for against bone mets, and it show marvelous response for Bsma. An oligometastatic patient with treatment of prostate cancer, we can use what is called the stereostatic body radiation therapy. It can delay the use of hormonal treatment for more than 2 years, and this will decrease the side effect of hormonal treatment. But the result will be better when oligometastasis will be diagnosed by PSMA rather than choline PET. For example, radical prostatectomy patient done radical prostatectomy 2011. It was Gleason 6 BT2Z clinical N0. The PSA was 1.2 nanogram in 2014. So he developed biochemical failure. So salvage radiotherapy for prostatic PET was done, but still PSA was not declined. When we use PSMA PET CT, it was found pre-sacral lymph node, which is treated by hormonal treatment, and we achieve 1.5-year biochemical free survival. So prostate cancer patients have many types, and we should tailor the treatment for every type. So we should have a good information for choose the management plan. PSMA enable us and give us information to tailor our treatment for each patient. So our home message is that gallium PSMA can help in selecting the right therapeutic strategy for each single patient, even with PSA lower than 1 nanogram per milliliter. It can detect early mets and exclude visceral mets and detect progressive and active lesion. Also, it has a therapeutic role. Thank you.